Well, welcome everybody to Optometric Education Consultants National Webinar Series, special Monday night edition. Our topic tonight is opioid issues for the patient and practitioner. With our speaker and my partner, Greg Caldwell, who is a graduate of the Pennsylvania College of Optometry, where he also did a residency. His primary focus is the diagnosis and management of anterior and posterior segment ocular disease. He's been involved in numerous FDA clinical trials. He has lectured nationally and internationally for many years. He's a co-founder and co-owner of Optometric Education Consultants and co-administration of a great resource, OCT Connect on Facebook. He has served as the president of the Pennsylvania Optometric Association and served on the AOA Board of Trustees from 2013 to 2016. And in 2023, Newsweek magazine named him one of the top eye doctors in America. So with that, nice warm OEC welcome for Greg Caldwell. Greg, take it away.
Thanks, Joe, and thanks for the introduction, and thanks for being here tonight and being the co-pilot. And certainly, I'm sure you're going to add some pearls and make this a good experience for all. So thanks for being here. Thanks, Vanessa. Disclosures, you can see here, really not too much I need to worry about tonight, but lectured Alcon to Dompe, Advisory Board Dompe to the Optometric Advisory Visionary Team. Received honorariums. I do have a non-salaried affiliation with PharmaNex. Nothing really there to worry about. Healthcare registries. I do sit as a chairman for Advisory Council for Diabetes Macular Degeneration. Really, this presentation was independently prepared by me. No one's asked me to say anything. If I do mention any products, it's without commercial bias or showing any superiority. Joe mentioned, half owner in Optometric Education Consultants. Most importantly here, though, everything has been mitigated with the regulatory bodies that's out there. Here is my practice. Joe and I kind of have the same philosophy. We love science. We love to read. We like to stay involved. But science is really at its best when you can use it in its office. I attended the OGS meeting this year, and every year they're talking about growing ganglion cells and putting them in petri dishes and crushing them and seeing if we can do neuroprotection and all the cool stuff that maybe eventually will make it to the office. So Joe and I try to watch that literature really, really closely, see new things that come out, and try to implement it into the practice. And tonight I'm going to try and implement and just share different techniques of pain management whenever these patients come in with these large corneal abrasions. If you do have opioid ability, hopefully you'll reach for the opioids. You won't be as scared to use them as you might have once been. Or maybe you'll go for some of the alternatives that are out there because maybe the opioid is not the best for the patient. So we're going to try and take some of the science that's out there and put it to clinical use. Here's the building. Here's, the exam lanes. We do have an optical. I do have to update this picture. We do have the 16:9 and double screens now, but, we have electronic health records that's out there. So here's the agenda, and I don't really go over an agenda a lot of my meetings, but, I'm suspecting there's a lot of Pennsylvania docs that are on here, along with other states that need this as a requirement. So when I've combed all the different state associations and state requirements, not really the associations, but the state boards of optometry, and looking for the requirements, some had to talk about the crisis and the pain definition and the grading scales. And then are there allergies to opioids, and what are the alternatives, and what's tolerance and addiction, and you show some cases, and you have to always do question and answer. So really I put that in there so that it's in the handout, it's in the slides, so that if you ever get questioned about what was covered, that hopefully this course will help cover you for that 2-hour restriction that most of us have that's in our state licenses. Well, with that being said, Joe, if you want to launch that first polling question, I am taking this course, and you can click all that apply, because you have a DEA license, and it's required. You need some pharmacology credits. I'm interested in the topic, or, if you have a different reason, maybe just put it in the chat box. And, remember that the chat box is a good way to communicate with us. This is, synchronous virtual, and Joe will monitor it. I have it open right now, and I'll see if there's anything that pops up. So,
People found the polling questions and doing very well.
yeah, we have 129 people logged on tonight. Great. You see that down there now. Well, welcome everyone.
All right, looks like we are slowing down here, so I'm going to put the display up. Awesome. Really, the greatest the number are people who need the pharmacology credits for their license, and a good number have a license or they have a license and it's required, and a number are just interested in the topic, and one person will be putting a comment in the chat box. Excellent, Greg.
Perfect. Yep, and I see some people putting B and D, and I see that in there. All the above. Good. All right. So let's move in. Let's get rolling here. So why are we required? I'm not going to really read this busy slide to you, but the point is just from 2018 is where a lot of these mandates started to come from. And when they looked back over the years, there were people dying from overdosing on opioids, the misuse of an addiction to opioids. There was a national crisis. There was misuse. Billions of dollars a year were happening. 21 to 29% of the patients were using a chronic pain med and started to misuse them, right? 8 to 12% develop an opioid disorder from using these chronic pain meds. 4 to 6% misuse prescription opioids, transition into heroin, and now maybe some other narcotics that are out there. 80% of the people who use heroin first misuse the prescription opioid. And you can see here overdosed increase, large cities increase. And so, it just became a crisis. Now, I want to point out a couple words here is that, chronic pain med misuse. We don't really use these in optometry for chronic pain. So that's what I kind of want to transition. I just helped PCO with an 8-hour course. There's a requirement out there. And so they had me do Tracy offer all, and I do 6.5 hours. I think Carlo Polino did 1.5 hours of it, and then we did the other 6.5. And we have this concern. We use all this misuse and overdose, and I don't want to take it lightly, but I also don't want to scare us away from a very good tool that's in our tool belt, that when it comes to using an opioid. So the HHS and the NIH, the what is it? The Health and Human Services and the National Institutes of Health, they got together and they got with the pharmaceutical companies. They wanted to have safe, effective, non-addictive strategies. They were looking for innovative medications and technology, and we'll touch a little bit on that tonight, and improve the overdose prevention that was out there, right? So now I think what's happening, if you look at the barometer in the United States, is that we as docs, are not really the cause. We have all this illegal kind of fentanyl that's in our country right now. And so there's two kind of crises going on. I think we're getting the doctor crisis under control. We're still in a sense creating some issues, but we got a kind of a bigger illegal type of narcotics that are out there in our country. Now, again, when we do these and I comb through the state boards, you have to talk about pain. So we'll talk briefly here on pain. And, pain is important to our survival. Pain is not bad, right? You can have a pain in your side and you go, what the heck is that? I better go to the doctor. And then, they find this, this tumor or lump or this growth on top of your kidney, and they're like, oh, lucky you came in at this time, because if it would have waited another 6-12 months, it could have been even more serious or life-threatening. Pain is not always, a negative, right? It's in our body. It's there for a reason. And it's a perception of a harmful stimulus. Pain can also occur in the absence of an injury long after it's healed. Pain involves humans with information about tissue damage and stimuli. Pain is a protective in two ways. It removes the patient from the stimulus, and you learn an association to avoid that. And I always tell the story of, I remember we got this new tractor whenever I was a kid. I was probably, I don't know, 8 to 10 years old, just learning how to cut the grass. And we got the new tractor and looked at it, and the muffler was all chrome and shiny. And we cut for the first time, and Dad let me cut in the circle, and we were all done, and I was proud, and we, swept it all off. And the muffler was not, all shiny. It started turning a little bit, from the heat, it started turning a little black, a little, it wasn't as shiny. And I just got about ready to touch it, and Dad said, "Oh, whoa, that's going to be hot." Okay, so the next time, maybe a year later, I was able to cut the grass on my own, and I'm like, "Well, why is that doing that?" And I touched it, right? And man, I pulled my finger back, and my top of my finger turned white, and it hurt for a week, and the skin fell off. That's the memory that you have, not to touch that muffler. Even though Dad told me, and Dad was wise, Dad probably touched the muffler once too, but it took me to touch that, and you get that learning association. So pain is good in a sense in that way, as long as I didn't have any harm or lose my finger and so on and so forth. So, somatosensory system, I just like this picture. It just kind of reminds us that we have sensory modalities of touch and temperature, body position, which is proprioception. If I close my eyes, I know where my hands are in relative, that's proprioception. And then nociception, which is pain, right? And I like this because, it's showing where the pain gyrus is in the brain. That's where we sometimes talk about it being centrally located. And that's one part of it. And we have these receptors that talk to this part of the brain. But I thought it was kind of neat that someone drew this picture, and you can see the different parts here. I guess the gyrus or the gyri, or how that would be properly mentioned, is that, we can see here that the head and the eyes, and how much in proportion, the arms are okay, but the hands have take a large part of the brain. So I just kind of like this picture, just kind of remind us of that part of the brain that feels the pain, and then how much is dedicated to our face and to our hands and fingers and to our eyes in blue here. So pretty neat. And then, when I started lecturing years ago with Tracy Offerdahl, she taught me two things. She said, "Greg, if you're going to lecture in pharmacology, you got to really understand the immune system. You got to understand receptors, because that's really what the chemicals and the drugs plug into." And so it's a reminder that we have thermoreceptors, nociceptives, mechanico, and chemoreceptors that are out there. And obviously tonight we'll talk about nociceptors. And when it comes to the opioids, we're going to be talking about mu, kappa, and delta. That's how these medications plug into. Now, pain, again, is an unpleasant sensory experience associated with actual potential damage. It's subjective. Memories of events associated, again, touch that muffler that's out there. And then mental state plays a very powerful part. We see it with athletes in the Super Bowl. They break, a bone in their body. They're able to finish the game. And then when the game is over and the celebration is over, they realize, hey, I have a broken bone, and look how much pain I'm in. Or we know the soldiers that are out there. We hear it, daily, or we hear the stories if you Google it or go to YouTube of the heroic, where someone is shot themselves, but they're dragging two buddies off, and then they find that they've actually been shot 2 or 3 times when they get back to the barracks. So the mental status to overcome the pain that's out there, and we see it in athletes and soldiers all the time. And that scientific explanation in the brain not only perceives the message, but also has a descending neurons that can suppress the message that's out there. So, the brain and the body is just so complicated when it comes to, how we're wired, and all the different, signaling and blocking that's out there that help us, in a sense, just to survive. The pharmacology of pain. We typically tonight are going to talk about peripheral acting, and that's going to be when we hear us say peripheral acting, we're going to be talking about NSAIDs and ibuprofen. The receptors and the substance that we're going to be talking about very minimally will be substance P. So when you hear substance P, that's what's plugging into the receptors in a sense in the peripheral acting. When we talk central acting, when we talk about opioids, we have these mu, kappa, and delta receptors that are found all throughout our body that can talk to our brain, as we showed in the cortex up there. And then we used to get a lot of questions if I did this live, and people would say, well, how do like proparacaine and anesthetics work? They basically are signal inhibiting agents. They just prevent the signal from traveling to the cortex. So, some of it is just signal blocking, some of it's plugging into receptors. So we have central, peripheral, and then on this slide here, again, we added the signal inhibiting agents. I like this picture here. This kind of reminds me of touching that tractor that I did, that muffler that was very hot. And again, you can see aspirin would work in these receptors here, maybe calming down the inflammation, doing something that's analgesic in a sense if we were to take aspirin by mouth. But I thought this was really cool. Did you ever, in a sense, touch the muffler? Your hand comes off, but yet you then say, oh, ouch, right? So it's in a sense something's harmful. You're automatically kind of already pulling away, and then, hey, ouch, it's like a delay. And the reason being, again, that's how we're wired. If you look, we have this harmful stimulus, our hand, instead of it going up to the brain and figuring it out and so on and so forth, those different receptors that we talked about, pain receptors, chemoreceptors, thermoreceptors, they actually said, all right, they're being triggered. You're going to just pull that, it's in that muscle. You're going to pull that out of there before it even has to travel to the brain, figure out what's going on, and then pull your hand out. So just amazing just how we're wired. And we all probably have experience of, having that where your hand's pulling away and then you say the ouch. And again, that's just, again, how we're wired. And then you can see how we can go up to the thalamus, to the sensory cortex that we reviewed a little bit earlier. And then we have that descending pathway to either say ouch or, again, maybe talk to those muscles. So you have the ascending pathway, descending pathway with the sensory cortex. We got receptors, and we're going to talk about all of those things tonight. So peripheral acting, it's kind of, if you think about it, it's the substance P kind of working at the injury. And then central acting is just blocking these mu, kappa, and delta receptors. And I have a picture later coming up of where all these receptors are. So with that being said, let's do polling question number 2 here, just to kind of keep it interactive. If you go to that second button down, I just saw it says a new poll is up. Go share your response. It says, what type of pain does not respond or at all to opioids, right? This is now starting to maybe figure out, those smooth talkers that come in that might want to, hey, give me some narcotics on this type of condition. So is it nociceptive pain or is it neuropathic pain? Which does not will not touch, or opioids will not touch? Is it nociceptive or neuropathic? Remember, neuropathic pain, for an example, would be like herpes zoster, that post-herpetic neuralgia.
And Greg, you're good on questions. There's nothing in the chat that's come in yet.
Okay. Yeah, this first part's a little bit academic. We have to get a little bit out of the way for it to count as a course. So just kind of getting to 10,000 feet, and hopefully we'll get to 37,000 feet cruising altitude. So
Okay, we're coming in pretty well. I think in about a few seconds we'll just display, and a 2/3 to 1/3 is neuropathic pain over nociceptive pain, Greg.
good. So that is correct. If we were going to phone the friend, we would take the answer of the phone a friend and 66% and go with no neuropathic pain. Now, there are four major types of pain. This is maybe a slide that maybe we could, really debate, or there might be six major types of pain, eight major types of pain, but we're just going to talk about nociceptive, inflammatory, neuropathic, and functional pain. Nociceptive pain that's the result from an injury. Inflammatory pain, there's abnormal inflammation, inappropriate response by the body's immune system. We could probably just think of a marginal ulcer that happens from or a marginal keratitis that occurs from a contact lens, maybe abuse, someone wearing it too long, sleeping in it, and we get that marginal keratitis there out at the periphery. Neuropathic pain, pain caused by nerve irritation, sometimes, not really understood. But probably the best way to think about neuropathic pain would be that post-herpetic neuralgia that comes from that herpes zoster. And then functional pain that's out there, really no obvious sign. And, that's maybe like kind of the fibromyalgic patient. And then now that's kind of maybe being a little bit more uncovered and talked about with serotonin levels that are out there. And, not to take it too much of a deep dive into kind of functional medicine with functional pain. I think it's kind of neat how it's kind of has the two names. Now it's kind of being linked maybe to some, leaky gut. And 90% of our serotonin is made in our gut area. And if we have bad gut and bad food and inflammation, then that might trigger some different types of functional pains that's out there, kind of known as that fibromyalgia. So those are your kind of four types of pain, that we're going to talk about here tonight. This is nociceptive pain. This is a patient that comes in. His eye is very painful, and he says, I was hit in the eye with a tree branch, and I think I scratched my eye. And so this patient comes in, and we pull the lid down. Luckily, you can see he's pseudophakic, and he's the cornea was okay, but I pull his lid down, and I'm like, okay, what's going on here? And you can see maybe it looks like a cornea or it looks like a conjunctival laceration. So I numb his eye up, I get a couple of my instruments out, start moving some things around, and lo and behold, the sclera did what it was supposed to do. You could see I kind of dug around, got some forceps, and we found this nice little thorn that was in his eye, underneath, in that subconjunctival space, made a nice little laceration. But the sclera did what it was supposed to do. It took on the brunt. He didn't have, I dilate him, I take a look, and he did not penetrate anything beyond the sclera. So we don't really have to do anything with this conjunctival laceration. Really didn't have to send him anywhere. We got the foreign body out. We just have to watch him for a secondary infection. So covered with some antibiotics. A couple days later, maybe that day, started some steroids. But he was in a lot of pain. This was a time when I reached for some Lortab for this patient. This was a narcotic, type of situation to get him through. He did kind of stab the sclera. He lacerated his conjunctiva. We'll talk about some pain scales here. He was like a 4 or a 6 on a pain scale. So we talked about it, and he wanted to get a good night's sleep, which is another little tip. When I hear that, if he's not going to go operate any cars, that would be a good time to maybe offer some a Lortab or some type of narcotic here for this patient. And I might have said Lortab. I did Ultram on this patient. This was a tramadol. Sorry, I think I did say Lortab. This was a tramadol that I used on this patient, 50 milligrams, a couple times a day. We helped get him through his pain. So I did say Lortab earlier, but this was Ultram that I used on this patient. So tramadol. So this is nociceptive pain. Again, this big old thorn went in and lacerated and created this subconj heme. And, he healed up really, really nicely. And, within a 2 to 3 week period, he was all back to normal and up and running. But the first few days is what we had to get him through. And this is what these medications are for. So
Now,
pain is, go ahead, Joe.
If you can go back to the that image, that's a great image. And this is an interesting pain management type of situation because you're in conjunctiva and sclera, which is a lot less pain sensitive than the cornea. Now, cornea, there are many things that we can do, including pressure patching and bandaged contact lenses to ease corneal pain. But this type of pain, while it is not as sensitive as the cornea, it is hard to manage. And I can see where opioids would really be beneficial in this kind of patient. So, in terms of, sensation, innervation. It's pretty much a durable tunic, but it's hard to use the same things that we do for corneal pain on something like that. So this is where a great place where opioids do come into play.
And I see Tina asked, thanks, Joe, for that comment. Very helpful. Thanks for that. Good insights. And then Tina asked, how many days did you use the tramadol for? It was about 4 days that we prescribed it for. Obviously, 50 milligrams, you could take 1 or 2. Usually I prescribe about 6 maximum for a day. I think I did like maybe 12 for him, knowing that over the course of the 4 days, he's not going to have to take 2 tramadol. He could probably just take 1 at a time, every 3 to 4 hours, 6 hours for pain. And so, I mean, when it was all said and done, he might even had a couple left over, but it was about 3 or 4 days. The steroids, when we get there, we're going to talk about how there's different types. There's NSAIDs, there's Tylenol, and I think we forget the powerful part that steroids do provide some pain. So he was kind of doing something synergistic between the Ultram and the Maxitrol, or the steroid that was placed on this guy to help him heal up here. So about 4 days. All right, so pain is complex and confusing, right? So here is our patient that's has herpes zoster. Now this is painful, right? This is now kind of that inflammatory pain. We have an infectious type of pain, and maybe some nociceptive kind of going on here, but infectious, inflammatory, nociceptive. This really isn't the neuropathic pain that we're talking about that's out here for the patient. Once this patient starts to heal all up and we get her to a point where there's really minimal inflammation and minimal infection, there's no infection at this March 8th. From here, we're kind of switching over to now maybe if they start touching it and it's sensitive, because remember, where does the herpes zoster, where does the herpes simplex, where does that virus live? It's in the neuron. It's a neuronal virus. So now it messes up kind of the chemistry that's happening within that neuron. So now we get into some neuropathic pain here. I'm going to quit sharing here. I'm going to stop sharing for a second. I'm going to reshare because I don't think I shared the sound options. And now I think I can click on this and share here because I have a little video here. Joe, let me know if you can hear this when she chats. Hi, everyone. I'm here with Helen. And as we can see, if you put that coming through?
Yeah.
Okay. All right. So basically what I just want to point out here was just kind of I thought it was kind of neat. She talks about the shooting pain, sharp pain. And, I think it's kind of the conversion of kind of going from nociceptive inflammatory pain, kind of now going to that neuropathic pain. You'll see what I'm talking about here. Watch this video. Pull your head up there for me. We're just getting over some shingles here, some herpes zoster. And I was telling her about how it hangs out in the trigeminal nerve, and the trigeminal nerves, it's right behind, in a sense, the ear array here. And kind of show me where you were pointing there. You don't have to hold your hair anymore. Just tell me where you're having that pain
Right here.
Yeah, right in there.
Right here.
And then tell me about you're having kind of things kind of shoot over. Tell me how you were explaining that.
Every now and then I'll be sitting and I'll get a sharp pain and I have to go like that, my ear.
Yeah.
And there feels like the whole right side of the back of my head feels like a numbing along the base of my neck, all numbing up through here.
Yeah. And that's exactly what we were explaining is where this trigeminal nerve kind of hangs out. So she's healing up nicely. We're gonna get her all healed up here, and she'll be back up and running. So thanks. So again, pain is confusing. It's complex. Yeah, in a sense, she's getting from that infectious, inflammatory type of pain, nociceptive pain, and I think that kind of numbing and shooting is now we're getting into that neuropathic pain that is so hard to treat. Now, this is not to be confused with neurotrophic, right? So there's this big, buzz out there. Oxervate's been out for a few years. Neurotrophic is kind of the opposite. It's what we don't want with an eye, right? So this is what we call the stain without pain, is that we have this eye here with a little bit of staining. We have this eye here, which is, I don't know, 90%, of the epithelium is missing. This is like a Montana starry night over here in this left eye, but yet the left eye is comfortable compared to the right eye. The right eye is the one that's more painful. Well, that's because whatever over here, this toxicity, the chronic medication, the lacking of treating the dry eye, again, the body is complex. It actually down-regulated. And this is not good because now the pain is good in a sense. It signals back to the brain and tries to help us out. Now we are neurotrophic. We don't want this to happen. So there's neuropathic. That's the kind of the super sensitivity. This is neurotrophic. This is the opposite of, we're not really feeling this eye. And then, we test this in the office via, a cotton tip applicator. I'm working with Bro right now. They have an instrument. We might be getting the instrument. And what I'm showing you here in this video is, I have obviously a slit lamp camera here. It can do video. And I tell the patients, look, they can't hear you. So blink when you feel it. And you saw how when I went back here, just minimal touching. And the patient actually, as soon as I hit that fiber, Joe mentioned how innervated the cornea is, the most innervated part of the body. And as soon as I hit it with a fiber, they're blinking. Now watch here. I almost kind of carved my name, my initials on here with this. It's like a GAC here that I'm able to write, and I can drag that across. And you can see there's fluorescent in there. It's only fluorescent. There's not, fluorescein. There's not fluorescent there. There's no numbing agent. This is just fluorescein that's in there, and that patient couldn't feel it. And if I just back up a little bit, what I was doing on this patient, if we look, and I pause it, it looks like there's an early simplex busting out on here. And this is what this patient was. So I was using the test to diagnose if this was a herpes simplex, and we were able to get them on the oral medications. But that's a neurotrophic cornea from herpes simplex. This one here is a neurotrophic from a bunch of toxicities, chemicals going on the eye, and a dry eye that just wasn't very well managed. This is just another patient, how you can test for cornea sensitivity. You can just touch the eye. This patient really isn't feeling anything. They're neurotrophic in this right eye or the left eye. I can't really see where that's the right eye. And I'm checking all the different quadrants here. You want to test superior, inferior. Again, Joe was spot on. The cornea is the most innervated, sensitive. And we have to go through a lot of therapies where that cornea or that conjunctiva and sclera doesn't have a lot of pain receptors. Here I hit the eyelid with down below there, you'll see, and the patient starts to blink. But this patient is neurotrophic. That's just never good for the cornea. So we have neuropathic, neurotrophic, we got nociceptive pain that's out there. Neuropathic pain, it's not really the focus of tonight's discussion, but it's relevant because you'll see people coming in on Xanax and Neurontin and Lyrica, not really for an anti-seizure, but it has a secondary of action of maybe some decreased inflammation, nerve inflammation, or nerve damage. And so, maybe someone had a seizure and they were like, hey, my neuropathic pain from my simplex or my zoster is improved. Or you'll see people that are taking Ambien and again Xanax, that are using it maybe not as a sleep medication or anxiety because it actually helps with their neuropathic pain that's out there. So the neuropathic pain is hard and opioids do not respond to it. That's the key, that's out there. And so when you do an opioid diversion, some of the things that we want to say is, like, hey, a patient comes in and they say, hey, I had this herpes zoster and, Lord Tab seems to touch it, but man, I had some Oxycontin and man, did it really help me out. Scratch your head because, I guess there might be a 1 in a million, or could be that black swan that's out there, but in a sense, the rule of thumb is that neuropathic pain does not respond to opioids that's out there. So that could be a clue that's out there in an opioid kind of diversion, an opioid course like this, to remember. And that's why we talk about neuropathic pain, is to remember that it does not respond to aspirin or Tylenol, those analgesics, doesn't respond to the opioids. And that's why it's so hard to treat. And that's why you'll see things like tricyclic antidepressants and anticonvulsants, Neurontin, Topamax, and the different medications out there being used. Joe, I'm looking here and I don't see any questions. Do you have any comments before I go on to acute versus chronic?
No, none at all. Greg, why don't you go right ahead?
Okay, so here's the key. We as optometrists are doing acute treatments, cornea abrasions, cornea lacerations, someone that gets a stick in the eye, a thorn that lacerates their conjunctiva. And that's where we're going to live most of the time, unless you get a ptysis bulbi or some type of, maybe chronic high pressure eye, maybe from a central retinal vein occlusion. Very rarely are we going to be working with chronic pain ocular patients. It's going to be mainly acute. And remember back when we started talking about how did we get here, it really isn't the acute patients. Now, anyone that takes an Ultram, a tramadol, or a Lortab 1 time, 2 times, yes, if their pharmacogenetics are set up, they can become addicted. But if you remember when I was going through all those statistics, it was the chronic pain patient that is out there. So it's more the chronic pain patients that, in a sense, transition. Not to say an acute person can't transition to addiction, but it's the chronic pain patient that transition. And that's important to understand the goals. If I had chronic shoulder pain, my goal for that is to get me as comfortable to kind of live a daily life. Or, say I had knee pain and I think everyone knows I like going to Disney and walking around and just, watching the customer service and just seeing all the different things that happen. And let's say I had some knee pain and I wanted to go. The goal of chronic pain management, let's say my knee pain was chronic, I wanted to go and I wanted to walk around. The goal is not to make me pain free. The goal in chronic pain management is to just allow me to live a normal life. Maybe that knee pain is a 7 or an 8 on a pain scale. And if I can get it to a 1E or a 2Z, I would be able to walk around and be able to enjoy the parks. Now, acute pain is to try and get that as close to 0, try and get that patient comfortable for that short period of time that's out there. We're trying to minimize the amount of pain. We're trying to minimize the amount of adverse drug effects with the pain, but they are totally different. One, you're in the hospital, you have a broken bone. Are you comfortable? Are you okay? We're going to get you healed up. We're going to get you out of here in a short amount of time. That's totally different than someone that has bone on bone in a knee or some type of arthritis or tendon problem, and they're trying. So there is a difference out there. And that's why, we need to be careful as a profession of optometry with these, but don't be scared to use them. It's a great tool in our tool belt. So I want to teach the caution, but I don't want to make it where people are like, oh my gosh, there's an opioid addiction out there. I don't want to be a cause of it. In the acute situations, we're not going to be there. So pain assessment scales, it adds data to the patient, how they're feeling. Everyone's a little bit different. You have the people that come in that have, an abrasion on their eye, and, a female with a 6 millimeter abrasion, a guy with a 1 millimeter abrasion, the guy being a guy, myself, it's like, oh my gosh, that's an 8, and a 6 millimeter abrasion on a female. Yeah, that's like a 5 or a 6. Everyone's a little bit different, right? Us guys were a little bit wimpy with pain. So sometimes a pain scale is good to help kind of figure out where we are and try to use whether or not we think an opioid would be useful. So with that said, do you use a pain scale when you're prescribing, let's say, narcotics, or really try to assess any pain that someone comes in? So if are you using a pain scale, let's say at all? Yes, no, I don't prescribe narcotics, or I'll place a comment in the chat box. So just kind of curious here out there regarding pain scales.
Interestingly, Greg, probably I think it was last week, maybe the week before, I had a woman who was gardening and scratched her cornea with a bromeliad. They have like a little serrated. Can she even had a picture of it with little serrated edges, and she had an abrasion, linear going right through her visual axis, and it was pretty significant. And her pain tolerance was really quite good. I mean, I was surprised at how well she was tolerating it. I still treated her fully because I wouldn't want her to be after hours and develop more pain. But I was really shocked at how little pain she's actually
Yeah.
having.
Especially centrally located, right? Jeez. Yeah.
Mhm. All right, I think we're doing pretty well. So the majority are not prescribing narcotics, so they're not using a pain scale, but some a good number of people are, and they do use a pain scale. So I guess of those who are prescribing narcotics, they do use a pain scale.
Good. So let's chat about a pain scale. And, I use it, no, I don't use it on every cornea abrasion. If I have someone coming in and, it doesn't seem to be adding up, or I'm a little confused, a pain scale can maybe add some, some clarity, start bringing some calmness, some discussion to the case here. So, I'm not like this here, a hospital room where, I got my pain scale on my wall here in my office, right? We do have the access, as you saw in the video with our patient with herpes zoster. You saw the 2 computer monitors, which is nice in the room. And here I just took pain scale, went to Google, just typed 2 words, pain scale, hit images right here, and get all kinds of pop up. The one down here, it's like a cut off on when I crop this, is the one I like to use is kind of like this one right here, but it's got some words to it in the description here. So I made it a little bit bigger here. It's kind of a combination. Some people can relate to, green to red. Some people can relate to smiley face to sad. Some people can relate to 0 to 10. And then maybe they have to read and you feel some pain or discomfort. Over here, the pain makes it difficult to concentrate. The pain is difficult, intense. So, sometimes, it's nice to bring clarity to the case. I'll tell you that anytime I prescribe a narcotic, I pull this up. I just wanted to have it documented in the chart. Use the pain scale. The patient was a 5 on a pain scale. So I use narcotics probably for my patients, not myself. I use narcotics in the practice probably 4 times a year. We get we're in a pretty rural area, get some people, and you'll see some cases here that are coming up where, they're sticking themselves with screwdrivers. You got people sticking themselves with thorns in the eye. Those are probably the ones where, it's not like a little scratch. Like Joe mentioned, we can do some alternatives like bandage contact lenses and cyclopleging a patient to help out, pressure patching that's out there, some alternatives. But and the weakness of a pain scale is, and you're going to see I have coming up here some pearls. Someone that's a 4 versus a 6, that could be totally different in the way we prescribe. This could be maybe ibuprofen and Tylenol, and once I get to a 6, I might be doing some tramadol that's out there. So, and then get to a 6 and a 7, maybe I'm reaching for some Lortabs. But, a combination scale, again, I don't have it really hanging in my room that's out there trying to be like a hospital. I can just Google it real quick. And again, it does at times get some clarity and a good conversation. Maybe the patient's just, okay, my eye hurts, da 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 da. And it just kind of redirects them and breaks maybe some of the panic that they think that they might be losing their vision. So when it comes to treating pain, we have our non-opioid groups. We have acetaminophen and Tylenol, which is totally different. I'm really not sure really how it works when it comes to the analgesic side. And then we have NSAIDs, your ibuprofen, your naproxen sodium, which is your substance P. Then I think we forget about our glucocorticosteroids, right? Methylprednisolone. And in this case, I threw in Maxitrol and Turbidex, that we use all the time. Don't forget that does have an analgesic effect by taking away some of that inflammation. Then when it comes to opioids, we have codeine, we have hydrocodone, and Ultram that are within the wheelhouse of optometry. I've never really found codeine to work really well for ocular pain. So when it comes to opioids, at least in Pennsylvania, I have access to hydrocodone, which is Vicodin, and there's some other trade names, and then tramadol. Tramadol is really, in my opinion, optometry's friend here. So if you're going to prescribe an opioid, I would go with tramadol as kind of maybe you're testing the waters that are out there. So with that being said, I just have a fun question here because we're going to talk about the schedules. Marijuana is allowed in a state like Colorado. I know there's other states to be used recreationally. Is it still considered illegal by the FDA? It's allowed in Colorado, but is it still considered illegal? And I have the chat box open, so I don't see much going on. I see some people putting in some answers, which is great. That's a good way to be interactive in our synchronous virtual type of course.
Okay, people are weighing in very well. We have a strong opinion leaning one way, so I'm going to give a few more seconds. Let's display it.
Perfect.
And the majority say yes, it is still considered illegal by the FDA in Colorado.
And that is the correct answer. Again, polling the audience, going to the friend. If this was who wants to be a millionaire, that's the way we would go. So the answer is yes, it's still considered illegal by the FDA. However, the state has said, U.S. government, leave us alone in Colorado. You don't have to come in and arrest us because we are keeping it, we are allowed to do it in this state as a recreational. So the FDA just ignores it because the state has, in a sense, overridden the federal laws. So, I always tell people, be careful. Airports are owned by the counties and local governments, but then it's federal property. So, that's why when you go to the Colorado airport, you see all those sniffing dogs that are there. Just be careful because when you get on that airport property, it's kind of federally, right? Federal agents and so on and so forth. So don't try and get it into your homes or whatever by bringing it home. If you want to do it in Colorado, keep it in Colorado. But yes, it's considered illegal by the FDA, but they just ignore it. So let's talk about the schedules. It's just kind of a cute way to kind of dive into the schedules. Schedule 1, that's your heroin, that's your marijuanas, your LSDs. Then we move into Schedule 2, and the whole idea when we go 1, 2, 3, 4, and 5, 1 is the most addictive, 2 is not as addictive as 1, and as you go on, 5 is the least addictive of the categories. In here now you see OxyContin, but then you can see again in 2013, 2014-ish, how we in Pennsylvania were legislated out of using hydrocodone, because we were allowed in Pennsylvania to use 2, 3, and 4. We're still only allowed to use 3, 4, and 5 in Pennsylvania. Let me re-say that. 3, 4, and 5. And we still are allowed to do 3, 4, and 5, except that the POA went and fought, and we got that kind of what they call the hydrocodone fix. We're allowed to use hydrocodone, which are 2s in Pennsylvania and by the FDA. But we can't use the whole category of hydrocodone and methadone and fentanyl. We just can only use what they call the hydrocodone fix, the hydrocodone preparations that are out there. I do want to point out that most of the ADD and the ADHD meds fall within category 2. And then we get into the scheduled 3s, which is now you're getting into your codeines and your Lortabs. And then right here, Ultram or Tramadol, this is where you're kind of if you want to dip your toe and start using some opioids for your patients in a very safe way. And I say that because, in the chronic pain management patient, you'd rather use things like narcotics rather than ibuprofen because, if you use ibuprofen chronically, the doctors will always say it's not a matter of if you'll bleed or if you'll create stomach problems, it's when you create those stomach problems. So that's why we need opioids out there, because in a sense, when you start talking chronic use, they are safer. Now, I kind of use them in my situation is that if it's a severe injury, or at times if I hear the patient say, man, I got this ocular pain, if I could just get a good night's sleep, I know I can kick this thing and I can get healed up. That's kind of like ding, ding, ding. Did you say good night's sleep? Because I'm going to use the benefit of sedation, a side effect for this patient, as long as they're not going to go out, drive a car, drive machinery. I got to live in a very rural area. Hey, I can't really let my buddies down. I'm going to go run the backhoe today. Okay, we're not going to go and use narcotics. And then we have our Schedule 5s here. State by state restriction. We kind of talked about this in 2014, how hydrocodone went from a 3 to a 2. New Jersey, Pennsylvania, and all the other states are now fixing this that's out there. Yeah, that's right. Marijuana is now a Schedule 3. Yes, that is correct. Thank you, Michael. So that has been recently changed. So yes, let me get that updated into this slide deck. Opioids, narcotics, mainstay of therapy for treatment of pain. Here's really the key. There's no maximum daily limit. Keep that in mind. It's useful for acute and chronic. They mimic the actions of endogenous, right? So if we go out and we run and we get that runner's high, that's that enkephalins, those dimorphins, those endorphins, right? You get that endorphin high whenever you're running. That's kind of the mechanism of action that we are hitting with the narcotics, the opioids that are out there. So the mechanism of action that we're talking about is, again, Tracy was right. We're talking about these receptors, mu, kappa, and delta. And when you hit the mu receptor, you can see, and the kappa and the delta, we get analgesia. Then if you hit these receptors, you get some other types of action. So what happens is whenever you hit the mu and kappa, if you're taking narcotics, there's your meiosis, right? The pupil gets smaller. Here's the sedation that happens. Now the mu kappa gets hit, you get a euphoria. You get that kind of a little bit of a little high, a little buzz, maybe a little woohoo. Now, if you take an OxyContin, you take a Tramadol, you take a Lortab, and you get a little bit of I feel good, a little euphoria, that is not addiction, right? It's that mu receptor being stimulated. So some people don't like that feeling. I think I'm being addicted. I hear a lot about it. Some people like it, kind of chills them out for a little bit. It's that I get really happy that you have to be careful with. There's pharmacogenetics that's out there. Constipation is a side effect. The respiratory depression, we're going to talk about that. That's what kills the patient when they get plugged into the mu receptors. Again, the kappa receptors, respiratory depression that's out there. So analgesic, the opposite happens with the kappa receptor is the dysphoria, right? Oh my gosh, I just feel terrible on these. I think someone's chasing me. You know, Mickey Mouse is chasing me with a cleaver that's out there. That's the dysphoria from the kappa. The mu is the euphoria that happens. And you can see the delta receptor just plainly gives you analgesic. So, you know, why would you just not make an opioid that just plugs into the delta receptors? And the answer is the way we're wired, right? We just have far more mu receptors in our body, a less kappa and a few delta. So the problem is that even though the side effects are less with the delta, probably the side effects are less because we don't have many delta receptors that are out there. And you can see that these receptors are all throughout our body, these mu, delta, and kappa. And again, here they are here creating those side effects. And probably the biggest one that we have to remember is you're going to create constipation. You're just going to stop that gut from allowing food to go through. So if you're going to do a narcotic, a little pearl to write down from tonight's notes is if you're going to do tramadol for 3 or 4 days, you might want to tell the patient to get Senecot S. The S has the stimulant, right? And I can remember Tracy saying this, and I hear her all the time saying it. You can give a stool softener, but you need the mush and the push, right? So I think that was taught to her by a professor. I think when she does it, I hear her say that it was given to her by a professor. If you're going to do a narcotic, especially if it's going to be chronic, you got to do some type of stool softener and stimulant because that mu receptor is just going to stop the food from moving through. And now you're going to have constipation that's out there. So again, these receptors are all found throughout the body. And this is just kind of showing you that there's mu, there's delta, there's kappa. You have all these endogenous peptides and opioid drugs, and they have higher affinities and less affinities. And again, this is nothing more than to show how complex this whole system is. When we come down to opioid drugs that bind to the opioid receptors, we have opiates that are morphine and codeine. We have semi-synthetics, and we have synthetic. Another little rule of thumb that plays within opioids and all of kind of pharmacology, the more natural things are, the more chance of you being allergic. Penicillin is natural compound that's found in nature, and that's how people can be allergic to penicillin. And then what they do is they make antibiotics that become more semi-synthetic and synthetic. So if someone is truly allergic to morphine and codeine, then that's why you would jump to maybe something synthetic that's down here, like your non-morphins that are out there, like fentanyl and tramadol and your methadone that's out there. So you have your opioids, your semi-synthetics, your synthetics. You can kind of see where they all fall on this scale here. So formulations play a role, acute and chronic. You have immediate release, chronic release. Pretty much we're going to be playing in the role of immediate release. We're not trying to get this steady basal rate of release that's out there to try and get someone that has knee pain, bone on bone, to try and get them to just an 8 to a 2 to allow them to lead a normal life. We're going to be using immediate release to get that highest amount of concentration for that acute pain that's out there. So a lot of times you'll see that as IR. You have to watch out for those CR, those chronic release versus immediate release formulations. And we can see it here with morphine. As you can see, morphine sulfate, immediate release, morphine sulfate, continuous release, CR, or IR capsules. So when you're going to prescribe, you want to make sure you're going to prescribe something that's more immediate release, because we're going to be dealing with those acute patients. Now, morphine is what's used as the base, right? That's our comparison, kind of like in glaucoma. If we're going to bring a new agent out, we always have to make sure it's, not inferior to timolol. So we always compare it to morphine when it comes to comparison of strength. And you can see hydromorphone. It's one of the strongest that's out there. It's very potent. It's used for severe pain. You can see that 30 milligrams of morphine, it only takes 8 milligrams of hydromorphone. So it's a very, and it's immediate release, and it has an extended release, but it's used for a very severe pain. It's very potent. Again, you can see the 8 milligrams compared to 30. Now, when it comes to codeine based, we have our codeine. Remember, it's naturally occurring, so people could be allergic to it. Then you have your hydrocodone, that's more semi-synthetic. And then you have oxycodone, Schedule 2s, Category 2s, and again, semi-synthetic. Now, again, this is an opioid awareness type. So you might have someone that comes in here and says, I have this chronic cough, and they've been giving me codeine, and it works, but man, when they give me that oxycodone, it really suppresses that cough. Again, maybe a fast talker, because we go from that naturally occurring to that semi-synthetic. In that formulation and redoing of that semi-synthetic codeine, the molecule changes where we now don't get the cough suppression that's out there. So again, in an opioid diversion course, that might be someone coming in because Oxycontin has a high street value that's out there, right? So they can come in saying, oh man, if you can prescribe me that, that would be great. Now, the good news is most states don't allow oxycodone, so we don't get hit on that, or our out is we're not allowed to prescribe it, so sorry. But there's your kind of codeine-based type of medications. I've never really found codeine to really work great on eye pain, but it is an option for us, at least in Pennsylvania. And I know a lot of the other states. I just practice in Pennsylvania and I can prescribe it. There's Tylenol 1, there's actually Tylenol 2 and 4, there's Tylenol 3. The short of it is Tylenol 3 is prescribed because it's the best ratio that's out there based upon the acetaminophen. You can give 2 tablets here of codeine of Tylenol 3. You're going to get 60 milligrams of codeine. You'll get 600. If you wanted to get the 60 milligrams here, you're going to get 300. So basically, all you need to know, Tylenol 3 is what's on the pharmacist's shelf. If you tried Tylenol 2 or Tylenol 4, they're going to say, hey, look, we don't keep it. It's going to be 4 or 5 days before we can even get it. So they're just going to resort back to Tylenol 3. So just play around with the ratios here, and you're going to see that the ratio here is going to be important, is the acetaminophen. You're only allowed nowadays, and you could do it for acute pain. It used to be 4,000 milligrams a day of acetaminophen. So 500 times 2 is 1,000. You can do that 4 times. I still do that for my acute pain patients. It's a liver issue thing. For chronic, right now, if you're going to do chronic, you only want to do 3,000 milligrams a day. So 500 times 2, so 2 tablets of extra strength Tylenol 3 times a day is the maximum dose that used to be 4,000. All right, your oxycodone products. You have your long-acting extended release. Again, Oxycontin continuous release, but you have Oxy IR. So again, watch out for those immediate release. Watch out for those continuous release. And within the oxycodone products, we have Percodan. No one ever prescribes it. I'm not even sure a pharmacist has it on the shelf, but it's Oxycontin and aspirin. A Percocet is now a combination of acetaminophen and your oxycodone. And you can see, again, comparing it to morphine, it's 20. It's not 8 like the hydromorphone, but 20, still a little bit stronger, is needed than when it comes to morphine. And then your hydrocodone products, which most of us in the states with the hydrocodone fixes, and some states are allowed to do 2s, and some just got the hydrocodone fix. This is a slide that we can talk about. You have your immediate release products. right? One that has ibuprofen, really not used. It's these ones down here, your Vicodin, your Lortabs, where they have 5, 7.5, and 10, and 2.5, 5, 7.5, and 10 of your hydrocodone, and 300, 300, 300, 300, 300. This all changed whenever they changed the upper limit of Tylenol being 3,000. These used to all be all over the place. You still have a 325 here with Norco, but most of them are going to be 300 of the Tylenol or the acetaminophen, and then you're going to have 2.55. I tell you, if I have cornea pain and I'm hitting a 5 or a 6 or above on a scale, I'm reaching for 5/300 of Vicodin or Lortab. That's probably just a good rule of thumb, and I have some examples coming up here. You're going to take 1 to 2 tablets or capsules every 4 to 6 hours as needed for pain. And again, the 3 grams of the APAP, which APAP stands for acetaminophen. In a sense, it's a longer word that they use, in other countries, long drawn out. But APAP, when you see it, is your Tylenol, is your acetaminophen. And you can see it's pretty strong, right? 20 milligrams needed for it's a little stronger than morphine. So that's why, in a sense, it works well. And I find this to work well with cornea or ocular pain in that acute phase. Here is my favorite. This is really, again, these are your 2 kind of slides right here. Hydrocodone is, your 5 milligrams / 300 Vicodin Lortab, or your 50 milligrams of tramadol that's out there. They really don't use Ultraset that much when you talk to pharmacists. It's really not in the pharmacies. I heard a lecturer one time say, "Oh, I use it all the time." Maybe they do. Maybe they have a pharmacist in the area. But when you talk to the pharmacist, they really don't keep it. They just kind of just go tramadol. And again, you just, in a sense, don't want to exceed 400 milligrams a day. Be careful when you go to your electronic prescribing, is that you are going to have to be watching out for that extended release, right? So when it comes to prescribing, probably one of the best clinical pearls is just watch out for the extended release. You want to go, immediate release. Tramadol, 50 to 100 milligrams. Pretty much I do 50 milligrams. You figure out how many tablets. They can take up to 100. They can take 2 tablets. About every 6 hours is when you want to give it. Now, it does have a dual action. It has the mu receptors, and it also inhibits serotonin. So the only pearl that you have to be careful of is if someone is taking these medications that are serotonin reuptake inhibitors, right? So like Prozac, that's out there. Someone that's taking a migraine medication, they're probably not taking it on a chronic medication, especially Imitrex. When they get the migraine, they take it. So just be careful of your patients with Prozac. I have patients that come in with these serotonin uptake inhibitors. I'll make a quick call over to the family doctor, and they'll be like, "Yeah, doc, if you want to do 50 milligrams, 100 milligrams for 3 or 4 days, it's really not going to upset this cycle of it." But it's always, I think, worth a call to the general practitioner just to make sure if that's what you want to use. If you're, again, if they're on it, you might want to resort back to something like a Lortab or Vicodin in that situation, or we can go to some of the alternatives that we're going to talk about. All right. Polling question that's out there. When you see a patient in your office on methadone, always be kind to them because they're always recovering from an opioid abuse, right? So we all see these these methadone centers for opioid abuse. So, you're looking over and you see that they're on, metformin, they're on, some type of, high blood pressure medication. Oh, you see that they're on methadone. So, they're always recovering from opioid abuse.
Okay, people are weighing in. You're caught up on the chat. And it looks like
Yeah, and thanks, Michael. I
majority.
knew that back in early of 24, June, May, March, they did move that to category 3. So thanks for that reminder.
All right, so we are pretty close, 43, 57, 57, 58 saying false.
Yeah. So
The
again, I
rest
would
saying
go with phone a friend here, even though it's close. I see 42, 48. It's close, but I would go with the audience here. And let me just explain, and I'll get there in a second. Some miscellaneous facts. Fentanyl, the black box warning is out there. It's the most potent opioid. So if there's ever a test question that's out there, it's the most potent opioid that's out there. Now, methadone is reserved for those morphine and codeine allergic patients, right? Remember, these are kind of naturally acting, so we could use it. Here's the clinical pearl that I want to point out with methadone. Yes, methadone can be used in pain. And here's just kind of a real quick, dirty, if a kind of clinical pearl is that if a patient is using it twice a day, they're trying to get this kind of steady basal rate to control their pain to allow them to lead those normal activities. If they're taking it once a day, kind of a rule of thumb, if it's once a day, they're probably some type of, they're trying to avoid like some type of adverse event, some withdrawal symptoms, and they're using it in a sense to tickle that receptor to help them not to go back to the opioids that's out there. So kind of once a day is probably someone that's recovering. Nothing wrong with if you're recovering. And then twice a day is they're probably using it for pain. And if you go back and check, you look at their allergies and you say, oh yeah, they're allergic to opioids, they're allergic to codeine, and that's why they're using it for pain. So they're not, again, the audience, 58%, they're not always someone that is recovering from an opioid addiction. All right, and I agree. Should always be kind to all patients. I agree with that. So we should not judge, but then we quickly become judgmental. So that's just kind of a, when I first started seeing methadone clinics pop up, and then people coming in on it. We always assumed that they were recovering, and they're not always recovering. Pretty simple when it comes to pregnancy. A really quick slide here. Just use Tylenol. It's basically what it comes down to. Tylenol is the drug of choice. Don't play around with NSAIDs. Don't play around with opioids. Obviously, ocular pain, corneal abrasions will heal. We can use other types of medications, using Tylenol, using bandage contact lenses, other techniques when the patient is pregnant. If they're a chronic pain medication, that's outside of our wheelhouse. But again, Tylenol is safe. Avoid everything else. Opioid allergies, this gets a little confusing. When you take an opioid, you can see here that you get a histamine release. Some people will get a little red splotches. They'll get a little bit itchy when you give opioids. So it's not a true opioid allergy. And that can be why we want to point that out is our records, electronic records, things are starting to plug into the big system now. So we always want to be careful when we put an allergy into the chart that, that it's truly an allergy. And I remember, Tracy, talking about her father-in-law, and her father-in-law, before he passed, was in hospice, and they wanted to give morphine. He was in a lot of pain. And they were like, no, we can't give it. There's an allergy. And she's like, no, I'm a pharmacist. I know my father-in-law, this and that. And she went way, way, way back and found something in like I don't know, the 60s or so far back that said he had a codeine, and it basically was this little histamine release that occurred. And then they said, oh, you're having an allergic reaction. Maybe in the early days, that's what they thought, but now we understand through science that it creates a release of histamine. Some people can get these little splotches. It's what you're looking for is the shortness of breath, swelling of the tongue, the swelling, the hard to breathe, the heart stopping. And some people can get itchy and get these little hives in a sense when you take And we see it a lot when people are, maybe coming out of surgery too. We see these kind of histamine releases. If you do have an opioid allergy, true codeine allergy, you can do fentanyl. There's that methadone again. Meperidine that's out there, not used too much. Pretty much the fentanyls and the methadones that are out there. And just be careful for the assessing those allergies appropriately helps the practitioner sort through the actual potential and placebo allergies, fear versus drug seeking that's out there. All right. So let's go through this pain scale. And this is probably some, Joe always says, take pictures, screenshot, circle this in your notes. I use the pain scale and, patient comes in and let's say they're a 4. Okay, where do they fall? So on pain, mild pain, you can get away 1 to 3. You can do some acetaminophen, maybe some Tylenol, 2 Tylenol, 2 ibuprofen. You start getting to a 3, maybe a low dose, tramadol, 50 milligrams once a day, every 6 hours, up to 3 tablets a day for that, number 3. Again, that's the drawback of the pain scale. If there are 1 versus a 3, you're going to maybe do tramadol for a 3, some Tylenol and ibuprofen for a 1. You start getting up to a 4 to a 6, you might start to be getting in a 4, 1 to 2 tablets of Ultram. You start getting to a 6, you're going to start reaching for maybe some lower dosing type of Vicodin, like 5 of the hydrocodone versus 300 of the acetaminophen. That's your synergistic effect, the peripheral acting, the central acting, working together. Maybe 1 tablet every 4 to 6 hours. You start getting to a 7 or an 8. Now you're starting to maybe taking 2 tablets a little bit more frequently. And, if we're getting to a 10 on an eye problem, we probably have some type of laceration that's out there, and it's probably going to be referred out. But as you can see here, as we can move up the pain scale, we can start using our acetaminophen and our ibuprofens, moving into the Ultrams, then moving into your Lortabs, and maybe a little higher dose that's out there. So these are kind of Tracy and I worked on these together and put these together and talking to other practitioners that if you're looking for a little bit of an aid, this will help you out when prescribing. All right. I think it's coming down to one of the last polls here is one of the main problems with an opioid is the low ceiling effect, the high ceiling effect, or the lack of a ceiling effect.
And you're good on questions, Greg.
Perfect. Yeah, I have that open. Thanks, Joe.
Okay.
I'm monitoring it. Yep. But thank you for double checking.
Okay, people responding nicely. Good split. Looks like people are thinking about it. Looks like we're slowing down. All right. So the majority, over 50%, say the lack of a ceiling effect is one of the main problems with an opioid.
Yep. And that's it. Again, phone a friend tonight, and we'd all be doing well in this. And it's the lack of a ceiling effect. I would go with a high ceiling effect too. We'll talk about what that means here right now in this slide right here. We talk about, this ceiling effect, and the peripheral or Tylenol has a ceiling effect, meaning we can give ibuprofen at 200 milligrams, 400, 600, 800. Prescription strength ibuprofen is 800 milligrams. And if you gave it at 1,000, you're not going to get any more analgesic effects. So 200 is analgesic, but 400 is more, 600 is more, maximum is 800, 1,000, you hit the ceiling, right? The problem with narcotics or opioids that are out there is that there's no ceiling effect. So that's those mu receptors, that's tolerance that's out there. And so what happens is someone has that chronic pain and they're doing well, and then they become tolerant, so now they have to give a little bit higher. And then they get a little bit tolerant and they have to give higher, higher, higher. They still get the analgesic effect, but now the constipation, the respiratory shutdown, that's where the issues come with this. And so when people have tolerance and they're using these medications, recreationally to get that kind of euphoria, that high, now we start plugging into the breathing centers, and that's where we start having the deaths occur that's out there. So really the big difference with the narcotics is the audience is correct, 58%, or the other people that answered high, there's a very high or no ceiling effect is the correct answer with these medications, where peripheral acting do have a ceiling effect. And this is now where tolerance comes in, where you need a higher dose to maintain effect, or escalation or higher dose to maintain the effect of the analgesia or the euphoria, and tolerance happens to everyone. So, there was, last year I did this challenge, right? No drinking for 90 days. Not that I drink a lot, but it was kind of neat whenever I said, okay, I'll have a beer with my friends. I was like, whoa, I'm a cheap date now. So tolerance happens, whether it's to alcohol, whether it happens to opioids that's out there. Tolerance happens again. And if you're trying to use it for pain, especially chronic pain, or the patient is trying to get it for that euphoria, tolerance is, again, the definition is escalation or increase of dose to maintain effect. And regarding euphoria, it could be life-threatening because respiratory depression, right? People are using it to get high. That's our Prince, that's our Elvis, right? It plugs into the breathing centers, shuts it down, and we're going to talk about Narcan here very shortly. So again, we talked about constipation. Anticipate it. It happens to everyone. Senna S is out there. Again, you want to make sure that it has the S, the stimulant. You don't want to just have the mush and have it sitting there. You want the mush and the push. So all the side effects with opioids are constipation. Again, sedation, we can use it as our benefit. If I can get a good night's sleep. Euphoria, you're going to get that little bit, hey, I feel pretty good. I have a little high. That's okay. It's that one, it's like, woohoo, I can't wait to take this again. Okay, now we got to be careful with. Dysphoria, that's our kappa receptors. Itching, the histamine release, all normal. Vomiting, we get plugged in that chemotaxic zone, or the chemotherapy. What is it, Joe? CT, the chemotaxic zone that triggers the vomiting. And that's what you see when people come out of anesthesia, right? They drive home from maybe a cataract surgery and they're nauseated and puking. It plugs into that CTZ, that CT zone. Confusion, meiosis, we see the pupil shrink. Respiratory depression, that's what kills the patient. And that's why, like, hey, I'm going to take my opioid, I'm going to have a couple beers and a whiskey and a glass of wine, and I'm going to sleep this off. Be careful, because that respiratory depression, benzodiazepine, muscle relaxers, sleeping agents. I'm going to take a sleeping agent. I'm going to take some alcohol. I'm going to hit this with a Lortab. And you can see here we have to be careful. And this is all kind of neat. The little picture here showing all the different side effects that oxycodone, as it plugs into the mu, kappa, and delta receptors that are out there. Withdrawal symptoms of a patient, we have short half-life agents that are likely to cause abrupt disruption, right? These are short agents, so they plug in, then all of a sudden the sweating, the sympathetic tone, the increase in the heart rate, the blood pressure, mydriasis, the agitation, the irritation, the irrational behavior that's out there. And again, this is what kills the patient when it plugs into the breathing centers and the patient is told not to breathe. Again, they keep taking it to get the higher and higher effect because there's no ceiling effect. They want the euphoria, and that's what then now starts to kill the patient, is the respiratory depression. And that's where this comes into play. If you look at morphine, and if you look at Narcan or naloxone, you can see here that they look very similar. And the good news is Narcan has a higher affinity for those receptors. So when it's plugged into the breathing center, this is no joke how this stuff works. You talk to people that have administered it, you see it in movies, the person is out, squirt up the nose, squirt up the nose, squirt up the nose. Patient wakes up and can breathe. And that's literally because the Narcan has gone and knocked off those receptors, and now they can breathe again. That's out there. So that's what they use in overdosing when you see Narcan. And it's not like plugged into the movies. That's literally how it happens. This is one of the things that they came out of. They tried doing this. It doesn't really work real well. But again, this came out of the meeting of the HHS and the NIH, is that they tried to put an agonist and an antagonist together, right? So put them together in the same medication, less respiratory, less abuse. They're not really working real well, but that's where they were trying to get and work around with the drug companies that are out there for this crisis that we're in. And I forgot to mention at the very beginning, this is our third opioid crisis in the United States. It seems to kind of hit about every 100 years. If you go back 100 years, we had one. You go back another 100 years. And if you go back through history and get outside the United States, there's been opioid crisis, throughout all of history, once that opium was, discovered, in a sense, that's out there. So substance abuse history, avoid all opioids in a patient that has a substance abuse like heroin. So this includes tramadol that's out there. So someone that comes in and they said, hey, yeah, I'm a recovered, I was on drugs, heroin, so on and so forth. Even avoid tramadol. It may trigger that dopamine reward center. When it comes down to alcohol abuse, it's out there. It's a judgmental call. Other abuses that are out there are people that were amphetamines and alcohol. The good news is when it comes to eye, we have other alternatives that are out there. Psychological dependence was the formal term. We now call it true addiction. True addiction, very simple, compulsive use despite harm. All right, I see that there's a bowl of glass right there, but I see 2 Oxycontin in the bottom. I don't care. My hand's going to get cut up. I'm going to reach into the glass and the razor blades, and I'm going to get those 2 Oxycontin so I can grind them up and get that euphoria. That is what true addiction is, despite, compulsive use despite the harm. It's very simple. 4 words, compulsive use despite harm. And it could just be something as, I'm going to walk outside in the freezing cold and stand for a couple hours until, or a couple minutes until the drug dealer shows up. We're just going to do something, stand in -degree weather without a jacket on. Again, compulsive use despite the harm that we know that can happen. So the quality of life is not improved by a medication, and then eventually it becomes compulsive. Wanting without liking is true addiction. So anytime we do these diversion programs, we have to talk about true addiction, which was formerly known as psychological dependence. Identify those behaviors of abuse: fast talkers, strange allergies. I lost my meds. You won't believe it. This is the 3rd time this week that I just dropped them and they went down the toilet. Excuses of why they need strong. Hey, codeine is good for a cough, but man, that Oxycontin can really suppress my cough for me. Watch out for those. I need the strong pain medication, but not everyone out there is doing that. So kind of listen to the patient, listen to what they're doing. Not everyone is trying to abuse opioids whenever they come in. Avoid getting bullied, avoid being judgmental. And there are tools out there like these databases, these prescription drug monitoring programs. I do have an Oklahoma license, so Oklahoma has one. Pennsylvania has one that you can use that's out there. Now, I'm going to try something here, Joe. I see I have 14 minutes about. I'm going to try something here and see if it works. I'm going to see if I do this, if I share this. Nope, that's not what I wanted. Let me see. Stop sharing. I'm going to pull this over. Let me see if I can do this. If not, we're going to try something else. All right. Can you see my Google screen, Joe?
I can.
All right. So I'm going to go here. You can see I've already Googled prescription drug monitoring at my practice. I have it saved as I guess a link, whatever that would be called, a favorite. I've already looked it up. A bookmark. Thanks, Joe. A bookmark. I have it saved as a bookmark. And I already kind of Googled this so that it would pop up. And I want everyone to realize that these are out here and you have to register. I've already registered because I prescribe these. And when you prescribe them, what I do is I log on to my prescription monitoring program. This is, it's a state, so you kind of have to go through and, register. So it takes time. So if you're going to do this, I would encourage you, like in Pennsylvania, to register yourself. You have to just put your license in. And this is all it is to it. You can see I'm logged in. It's going to do a date range of about a year here. I'm going to type my name in here, Greg Caldwell. And you would type your patient's name in. You're going to do a date of birth. We're going to do April 1970. Oop, going the wrong way. There it is. I was born on a Friday. That is correct. And now we're going to do this date range. You can do some other things here. We're just going to search the patient. You can do multiple patients if you want, I guess. But we're going to search this right here. And you're going to see that if that popped up, can you see that? Patient not found. So I haven't taken an opioid, but other things could show up in here, like Xanax and Valium and so on and so forth. That's as quick as it is. Okay. What I do then in my chart is I did a prescription drug monitoring program search. Greg Caldwell does not have any medications. I'm going to prescribe Ultram, right? Or I don't really type out the prescription drug monitoring. I just do PDMP, type that in, and that's as quick as it is to search. So there it is. But my point is, now if I wanted to search, okay, Greg, he has a place in South Carolina, I can search down there to make sure that nothing else has shown up. So that's how quick it is. That's how you can do it in the office. You can see here I am registered as an optometrist for the Pennsylvania Drug Monitoring Program. And that's how easy it is to do and quick it is. But it's quick and easy if you have registered. So go and register if you want to be able to do this in your practice. And that worked out. So that was, I thought that might crash and burn, but that worked out well. So, all right. So here's what the companies have done. The companies, let me move this back out of the way. Okay, so the companies have done things like this. You want to crush the original formula so that you can get it into solution to be drawn up into a syringe. So they put this gel on it. So again, you want to draw it up into the syringe because you want to be able to inject it. But if it's all lumpy and bumpy, you can't do it. Well, I've never done it, but I know that if you go on and you Google, how do I get this gel off, or how do I do this? Like you could suck on it for a little bit, let it dry. Again, some people will put it in alcohol, right? Rubbing alcohol. That's that definition, right? Compulsive use despite harm. They'll get some rubbing alcohol into their body because they want to be able to get that high that's out there. So these are all ways that they're trying to tamper, but then if you're addicted, there's ways that people will work around it. In the next few minutes here, let's talk about some alternatives and additions to opioids. We can talk about the NSAIDs, the COX-2 inhibitors, corticosteroids. There's alternative approaches like acupuncture, nerve blocks, spinal cord stimulators. But Joe talked about this earlier. We have bandage contact lenses when we have on the cornea. It's kind of hard to bandage the conjunctiva, but we can bandage the cornea. And there's a billing code for it, 92071. We can do Medrol dose packs. Remember that steroids do have an analgesic effect on there. All right, I see a question roll in here. Do you search in the front of the patient, or do you excuse? I just do it right there in front of the patient, Deborah. I usually just say, hey, look, I'm going to you have a severe cornea injury. Yeah, I see that, I want to use a tramadol. It has some side effects of, constipation, respiratory, they're safe to use at very low doses. Make sure you don't get confused and take 5 at a time, so on and so forth. Is it okay to use this? Yeah, doc, I'm going to get rid of the pain. Well, for me to do that, I'm going to do a real quick, by law, I got to search this. Okay, I'm going to do that. I type their name in, and just do it in front of the patient. And I even do it if I think that they're suspecting, that they're a fast talker. I don't really get that many of them, but I would probably do it right there in front of the patient. So yes, I do it usually in front of the patient, or always in front of the patient. Great question. So as we get back to alternatives, steroids, no one really uses the millipack that's out there. Prednisone, it's usually methylprednisolone. I heard someone talk about that, reached out to a couple pharmacists, reached out to Tracy, and no one really uses the prednisone millipack that's out there. When you're using steroids, remember, the glycemic control and the different types of things that can happen. But this is more for your chronic patients. This is, we're working with acute patients. Tylenol is amazing at 500 milligrams twice a day, coupled with ibuprofen. I'm just going to kind of skip through these slides here to kind of show you. Tracy and I wrote an article, but what you need to know when it comes to your pain relievers is 3,000 milligrams. It used to be 4,000. And then ibuprofen, if you think about it, 200 milligrams is what's in an ibuprofen bottle. 800 milligrams is prescription strength. 800 times 4 is 32. So 2, or if you take 3,200 divided by 200, that's 16 tablets a day of ibuprofen that you can take. So patients look at me all the time kind of freaky when I say, okay, I want you to take 2 ibuprofen, 2 Tylenol. That's if I'm just trying to do analgesic. If I'm trying to get some anti-inflammatory in here, they got hit in the eye, there's going to swell, want to get some inflammation to calm down, I tell them to take 4 and 2, 6 pills. Don't reverse it. I write it down. They're like, oh my gosh, doc, you're trying to kill me. 6 pills. No, I can write an 800 milligram 1 pill and get you 2 pills of Tylenol. But you kind of have to walk them through it. They're like, oh my gosh, that's a lot. You're trying to kill me. And then they'll be like, oh, I took the 4 and waited 2 hours. No, 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 no. If you take this here, even 2 and 2 or 4 and 2, it gets to the level of morphine. It just doesn't stay up there as long as morphine comes down. It gets up there, it stays, and then it starts to come down. So you can see here, and I found this, and it's not in your handout, as I was combing through some slides. It was really weird how it popped up today. This is Chris Putnam. This is a talk that Joe and I did. It was back, I think, in January 10th, I think was the day, but it was January of this year. It's on our YouTube channel. Chris did a pharmacology potpourri, and he brought this up where a single dose opioid and non-opioid, and it's in the JAM of 2017. You can look it up. And basically, they did 400 milligrams of ibuprofen. What I just told you, 2 and 2 versus 5 Oxycontin with the acetaminophen. Here's your Vicodin, right? Your hydrocodone. Here's 30 milligrams of codeine, right? You're getting down, I think that's Tylenol 2 because 60 is, no, that's Tylenol 3. Sorry, that's Tylenol 3. So Tylenol 3, Vicodin, hydrocodone, and 2 and 2. And no clinically significant difference in the pain reduction 2 hours among the single dose treatment. Now, that's 2 hours. That's about where this is going to last, where some of these can last a little bit longer. So I'm a big believer in 2 and 2 and 4 and 2. They work great for our patients as an alternative. Now, I'm going to go through this pretty quickly because I want to get to the cases. Basically, like always these questions, what about CBD? CBD doesn't work real well on eye pain. CBD, we're starting to learn more about it. It's becoming very trendy. We see CBD. What I want to point out is CBD at 40 milligrams can drive an IOP high. I don't really see much of an ocular use yet. It's probably the eye doesn't have the endocannabinoid system, but let's stay plugged in to see what's going to happen here. Remember, marijuana was illegal for many years. Then it became legal. Now it's category 3. And now we're doing lots of studies in this area. We're starting to understand the cannabinoid system, THC, CBD. Remember, the THC is what drives down the IOP. CBD raises it. So CBD alone, you got to be careful at 40 milligrams because it can drive it up. We're starting to see studies, since it's now becoming not illegal to do CBD, looking at for fibromyalgia, looking at it as an alternative to help us deal with patients that are addicted. And there's just a whole new, I have a whole lecture on it, but the key is it's not really great for eye pain at this point. Maybe some of the neuropathic stuff as we start figuring out where to go. I'm going to finish with a comment that our associations fought hard. You heard Joe mention I was president of POA in 2010. I was on that board for about 6.5 years. AOA. We should not be afraid to have a DEA license. I encourage anyone that's out there, spend the $800, get it, even if you don't use it. It really helps those that are volunteers at the state level. Joe's in Florida. I'm in Pennsylvania. FOA, POA, all the other associations that are out there, so that we can say, look, optometry is in this crisis and we're not a part of it and we're responsible. So thank you. If you do have a DEA number, I would encourage you to just part of the matrix out there. Don't be afraid. You can use it for acute pain, or just use it to help us fight our battles as we expand our scopes. Now, in the next couple minutes here, let me just go through here real quick where I recently used my DEA. So here's a patient that was looking with a curling iron. She was curling her hair. The daughter runs in and she said, "What, honey?" And the head turned, but the hand didn't move with it. And we have some well done epithelium, an S-char right here. So this was a nice big corneal burn. This was something that I would use a Lord tab, depending on where they are, or an Ultram. I thought this person was a fast talker. This guy works on small models. He's got these really sharp knives. He was working on something. And he's like, "Doc, I cut my eye. My eye hurts." I'm like, "Yeah, it's like a 6 or 7. I'm like, "Oh, come on, you're a fast talker." Then I look right here. You can see the cut. Then I used my OCT and I said, we know that this cornea is very innovative. He gave himself a nice, look how long it is. Look, I don't know, what's that? About 3.5 millimeters, 4 millimeters cuts, and it is 2/3 of the way down through the cornea. So he's 407 microns deep with a 4 millimeter. He's in pain. He wasn't being a fast talker when he cut himself with this kind of X-Acto type of knife that he does with his miniature models that's out there. Here's a person in my area that's working on brakes and tires, and he's using a screwdriver, and wham, it not only creates this little LASIK flap, you can see that the endothelial cells are already pulling in the sodium fluorescein into the stroma. We've got a subconch heme, we got a misshapen pupil, we have a hyphema, and if you look up under his lid, at least the cornea did what it was supposed to do, hit the cornea and went up into his upper orbit and created a conjunctival laceration. So we have a pretty painful eye. Hyphema, we're going to cycloplegia him, we're going to get him on some steroids, we got to cover this with an antibiotic, we got 2 lacerations, conjunctiva, cornea. This is a Lortab patient for us, and we got this person healed up very nicely with back to 20/20 vision. I showed you this one earlier, this guy that thought he was hit with just a tree branch, but he has a thorn that has created a conjunctival laceration, a big hemorrhage, and we got this person healed up nicely. And this was a DSEC procedure that the person didn't realize that he had to have follow-up, quit using the drops, thought everything was going to be fine, but ended up with an endophthalmitis. Had to get this patient back to Philly. "Hey, doc, can you give me something for the pain?" "Sure. Let me get you some Lord tabs. Let me get you some Ultram." And then back to Philly, this eye was eventually enucleated because they just couldn't save it. It became a ptysis bulby eye. But I was able to at least give him some pain comfort as he went back to his surgeon in the Philadelphia area. And the last polling question I'm going to have, Joe, before we move into the housekeeping is, I now feel better prepared to treat ocular pain. Yes, good review. I feel about the same or a bit better, or no, it wasn't helpful. And that will wrap up our talk. And I don't see much interaction tonight with this. So I see Deborah's last question there. Do you use it in front of the patient? We answered that. It's time to put any questions in. You do see the little red dot below the survey that popped up. You can start doing the survey if you want while you're asked after you answer the polling question.
Well, clearly, Greg, most everybody really benefited from this talk. Majority feel a lot better prepared to treat ocular pain. And some people think it was a good review. They feel a little bit better about the same. So that's very good.
Perfect. Awesome. Well, with that being said, I'm going to remind everyone that you can start the survey right there, that little red dot, if you want to click on that. And we've done the questions. I just want to thank everyone for attending. This was Opioid Issues for Patient and Practitioner. This was a synchronous virtual course. I want to thank everyone for attending and participating. And Joe, thank you for being a good co-pilot tonight.
You're welcome. I'm glad this went so well compared to our issue yesterday when my internet went down. I had to relocate.
So thanks, everyone. Thanks for coming. This will end the CE.